This video will be focusing on how to classify fractures of the hand using different descriptors. We will be discussing how to describe fractures based on the following. Number 1, anatomical location. Number 2, fracture pattern. Number 3, joint involvement. Number 4, displacement and shortening. Number 5, angulation and rotation. And number 6, open versus closed fracture. We will start with describing fractures based on the anatomical location, as we already reviewed in the last video. For the metacarpals, proximal and middle phalanx bones, you can have base fractures, shaft or neck fractures, and head fractures. Here you can see some examples. So first we have a base fracture of a middle phalanx. Next we have a D2 proximal phalanx fracture of the shaft. And then finally, you can see here there's a head fracture of a proximal phalanx. Head fractures are often divided into 3 grades. So grade 1 is non-displaced and stable. Grade 2 is unstable and involves one condyle, so one edge of the bone. And then grade 3 is unstable and comminuted, so it involves both condyles. This head fracture, so the one that we saw from the last slide, would be a type or grade 1, as it only involves one condyle and it's not displaced. In addition, the distal end of the distal phalanx is called the tuft, as we just reviewed, and so this would be a tuft fracture when broken. Next, we can also describe fractures based on the fracture pattern or how the bone breaks. The pattern can also give us clues about the mechanism of injury. Describing the fracture pattern is often in the context of shaft fractures because this is the longest and weakest part of the bone. So we'll go over some common fracture patterns. The first is a transverse fracture, and that's when the fracture line is straight across the bone. This is usually from bending the bone sideways, like cracking a stick in half. Here is an example of a transverse fracture of the M2, so the second metacarpal. The next fracture pattern we will talk about is an oblique fracture, and that's when the fracture line is at a diagonal, and this can be a short oblique or a long oblique depending on the angle. The mechanism for these types of fractures is usually from acute impact at an angle onto the bone. Here's an example of an oblique fracture that's a long oblique fracture of the proximal phalanx or P1 of the second digit. The next type of fracture is longitudinal, and that's when the fracture line is parallel with the long axis of the bone. These are less common but can happen due to a force with impact perpendicular to the long axis of the finger. Here is an example of a longitudinal fracture through the P3. Here we have a spiral pattern of fracture. These can look initially like an oblique fracture on X-ray, but in 3D they're actually more of a corkscrew pattern. These come from a mechanism that involves twisting of the bone. It's easier to see these with multiple X-ray views, so what you would get with a normal hand series. For example, here you can see that there's a fracture in the proximal phalanx here, and on multiple views you can kind of see that it's more of a corkscrew appearance. Here we have an avulsion fracture, so that's when a chip of bone is pulled off by a piece of soft tissue, so generally a ligament or a tendon. You can see here's the avulsion fracture here, and generally you would expect to see avulsion fractures at the attachment sites of ligaments or tendons. The next type is a segmental fracture pattern. This happens if the bone is broken in 2 places and it leaves a segment of bone completely separated. This is uncommon in the hand, but worth mentioning, and this is not a hand X-ray. Finally, we have a comminuted fracture pattern. So this is when there are multiple fractures creating a shattered appearance of the bone. This is often due to high impact mechanisms in more traumatic injuries, and often happens at the level of the distal phalanx, but can happen anywhere. As seen in this X-ray, you can see that there's a comminuted shattered appearance of the proximal phalanx P1 of the second digit. Next, it's important to determine if the fracture extends into the joint, as fractures that do, called intra-articular fractures, can be more challenging to manage. Compared to fractures that are extra-articular or outside of the joint, it's especially important to restore alignment, stability, and congruity of the joint when you're treating intra-articular fractures to prevent long-term consequences like post-traumatic arthritis and stiffness of the joint. Here are some diagrams that show extra-articular fractures, so where the fracture line does not go into the joint surface, versus intra-articular, where it does extend into what would be the MCP joint here. And here's a radiograph showing a fracture at the base of the thumb metacarpal, and you can see that the fracture line does extend into the joint here. Intra-articular fractures can also be partial, meaning that only part of the articular surface is disrupted, or they can be complete intra-articular, meaning that the entire joint surface on this side is disrupted. And as you might imagine, complete intra-articular fractures are more challenging to manage. Another way to describe fractures is based on displacement, which indicates how much the fracture has caused misalignment in the contour of the bone. A non-displaced fracture indicates that the bone is still well aligned and will heal in anatomic position. An example of that is shown here. So there is a tuft fracture in the distal phalanx, but it is non-displaced. Displaced fractures generally need reduction to improve the alignment so the bone will heal in an anatomic position. You can describe the direction of the displacement in your description, like lateral, dorsal, volar, etc. So here is an example of a displaced fracture, and you can see that the displacement is lateral or radial because it's towards the thumb. You can only see D2, D3, D4, and a bit of D5 there, but you know that the thumb is over here just based on the alignment of the fingers, and so this would be a radial or lateral displacement of the D3 proximal phalanx fracture. A similar concept is that of shortening, which refers to a bone that is displaced so that there's overlap between the proximal and distal fragments. Here's an X-ray showing shortening of the bone, as can be seen with overlap between the two segments of the D2 proximal phalanx. You can see a bit of overlap there as well. That would be called shortening. Next, angulation, which is a similar concept, is important when describing a fracture because some degree of angulation is acceptable while some is not. Angulation is a type of displacement where the normal axis of the bone is disrupted and the fracture forms an angle in the bone instead of the usual straight axis. Generally, we describe angulation in terms of direction, so dorsal versus volar, radial versus ulnar, and with the degree of the angle. The descriptor is the direction the angle is pointed. So, for example, this fracture shows dorsal angulation, remembering that this is a PA or oblique view. This is a dorsal angulation of 49.7 degrees. Usually the radiology viewing software on hospital computers has a tool that can draw the angle, and so you can draw through the axis of one fragment and then the second fragment, and it will calculate the angle for you. How much angulation is acceptable is based on which bone is broken, especially for the metacarpals. So in this table here, you can see for the index and long finger, ring finger, and small finger, they have a generally accepted angulation of the shaft, shortening of the shaft, and neck angulation. And then each digit is a little bit different, and this guides whether or not the fracture can be treated conservatively or whether it needs further reduction or an operation. So, for example, the radiograph in the last slide shows a D5 or small finger metacarpal neck fracture that's 49.7 degrees. Based on this table, the acceptable amount of angulation where you would not have to necessarily reduce it further is 50 to 70 degrees. So in theory, you could get away with treating this conservatively without further reduction. However, it is worth noting that these values are somewhat controversial in the literature. Another deformity that you may see is rotation, which can occur around a fracture when the segments of bone twist. You can see this sometimes on radiograph, but this is best seen on physical exam. So as you can see here in this photo, you have a scissoring deformity caused by rotation of the bone. Finally, you can describe a fracture based on whether it is a closed injury, i.e. with no break in the skin, or open with a break in the skin. Sometimes the x-ray can indicate an open fracture, like you see here. You can tell that the soft tissue contour is obliterated, but usually this is just identified on physical exam. While it often can't be seen on an x-ray at all, it is important to note this as it can change management. So that sums up how to describe a fracture as seen on an x-ray. In the next video, we will identify a few common hand pathologies.